So the topic of my talk today is management of infertility in PCOS. Though I am not an expert in infertility, as medical teachers, we are, as you all know, we are jack of all trades. So if there are some nuances or lacunas, please, sorry for that. But still, I would like to talk on this topic of management of infertility and PCOS. So, as we all know, that PCOS is a very complex disorder involving the endocrinological system of a female, and it affects entire pathology, endocrinology system of the female. This disorder is associated with persistent hyperandrogenic chronic anovulation, and it is associated with hyperinsulinemia, insulin resistance, which results in menstrual irregularity, infertility, and hirsutism. So, around 8 to 13% of women suffer from this disorder. 70% of them, they remain undiagnosed. And 50% of women with infertility, they suffer from PCOS. So, that is a large number. So, these women of PCOS, they suffer in different aspects. The first is the reproductive aspect, that is, they suffer from infertility, menstrual irregularity. And the major disorder or the pathology in them lies in the metabolic syndrome, insulin resistance, and type 2 diabetes. And also they suffer from psychological disorder in the form of anxiety, depression, and body image, because they suffer from obesity, hirsutism, and all these factors. So these are the clinical manifestations of PCOD. So we'll be mainly dealing with infertility. I'll be dealing mainly with infertility, while the clinical and hormonal, I will be dealing the clinical factors with PCOD, while hormonal will be taken up by the next speaker. So PCOD has different phenotypes. It is a spectrum of disorder. Few females, they suffer from certain things, and the other, they suffer from certain things. And some of the females, they suffer from all the disorders. So there are various phenotypes in this. So there are 4 major phenotypes. In A phenotypes, the females suffer from hyperandrogenism along with ovulatory dysfunction and polycystic ovarian morphology. In phenotype B, they suffer from hyperandrogenism and ovulatory dysfunction. In phenotype C, they suffer from hyperandrogenism and polycystic ovarian morphology. And D, that is the milder form, they suffer from ovulatory dysfunction and only polycystic morphology. So from A to D, that is the grading system from major to minor degrees. So some word about a lean PCOS. When we talk about PCOS, a female that comes in front of our eyes is an obese female who is having obesity, acanthosis nigricans, hirsutism, acne. But there is one entity called as lean PCOS that is a little bit different from the obese PCO. So these lean PCOS, they are less common, and they suffer, but they also suffer from hormonal, metabolic, and all the hematological profiles. It is altered in lean PCOS, and the derangements are comparable or less obvious as compared to obese women. But the treatment is same in both the females. So what is the exact cause of infertility in these PCO females? So the exact etiology is not known, but it is linked with genetics, that it runs in families, and siblings, they suffer from PCOS. So the main pathology here is the post-receptor failure, and that is the insulin receptor failure. There is increased serine phosphorylation at the site of insulin receptor and decreased tyrosine acetophosphorylation of insulin receptor that leads to hyperinsulinemia. and some genetic factors that leads to hyperandrogenism. So the ovarian milieu, it becomes hyperandrogenic and it leads to chronic anovulation. I will not go into much details as my next speaker will be speaking on this. I will mostly talk about the clinical correlations. So WHO has classified the types of anovulatory disorders, and PCOS comes under the type 2 WHO classification. Type 1, there is no FSH, no LH, that is hypogonadotropic hypogonadism. While in type 2, there is normal estrogen and FSH and LH levels. While type 3, there are no follicles, there is no estrogen, no FSH, LH. Then, what are the diagnostic criteria? There are the famous Rotterdam criteria by which we diagnose PCO, which involves the oligo and or anovulation, hyperandrogenism, and polycystic ovary on USG. There is an interplay of these three symptoms. So, any two of these symptoms, the patient will be labeled as PCO. Clinical, if there are two clinical symptoms are present, oligoanovulation or hyperandrogenism, there is no need of USG diagnosis. Now recently, guidelines have changed and the 2018 new guidelines have come up. These are the international evidence-based guidelines for assessment and management of polycystic ovarian syndrome. They were published by Center for Research Excellence in Polycystic Ovary Syndrome in partnership with SRA and ASRM. So according to these new guidelines, we have to classify the PCOS. These are the investigations, these are hormonal evaluation which has to be done for a PCO patient. The serum LH-FSH levels, serum androgen levels, that is serum testosterone and androstenedione, serum estrogen and prolactin levels. Out of these, serum testosterone and androstenedione are most important. According to the new guidelines, LH-FSH ratio does not have that much of importance. Then the test for insulin resistance is very important because these females have great insulin resistance, obesity. So for that, serum fasting insulin, fasting glucose insulin ratio and glucose tolerance tests, they are preferred. But according to the new guidelines, these serum insulin levels and has not much importance. More importance is given to clinical features. Then obviously, if they are obese, they have lipid abnormalities also. So according to the new guidelines, the PCOD criteria according to which we diagnose PCO, there should be more than 20 follicles per ovary, and that too we are doing on a transvaginal ultrasound by a 8 megahertz probe, and the ovarian volume should be more than 10 ml. So previously they were used to say that 8 or more subcapsular follicles with less than 10 mm in diameter and increased ovarian stroma. These were 2008 guidelines, but these new regulations, according to new regulations, these are the number of follicles they should be present in the ovary. Now, what workup should be done in a woman with PCO and infertility? So, these are the routine investigations we advise women. There's a husband semen analysis, tubal patency test, thyroid profile. Now, word about anti-Mullerian hormone. That is very important in a patient of infertility. It is a glycoprotein that is secreted by the granulosa cells. And as there are multiple growing follicles in PCOS, so the serum AMH levels, they are raised in PCOS. It is a marker for the ovarian reserve and it correlates well with the antral follicle count. But many people are disusing or they be wrong use of this AMH. So it should not be used as an alternative for detection of polycystic ovarian morphology or a single test for diagnosis. And normal serum AMH levels, they range from 2 to 6.8 nanogram per ml. So before starting any treatment for infertility, we should rule out diabetes, metabolic syndrome, hypertension, hypothyroidism, hyperlipidemia, vitamin D deficiency, and they should be treated appropriately. This is an algorithm for management of PCOS. First line therapy is always the pharmacological treatment in the form of clomiphene citrate and aromatase inhibitors. Second line is gonadotropins or laparoscopic ovarian drilling. And the third line is in vitro fertilization. These are the guidelines, but as and when they have to be changed according to the type of patient, age of the patient, the duration of infertility. So according to that, we can change the first line, second line, and the third line of treatment. So first and the foremost is the lifestyle modification, change in the lifestyle. Of this, first is the weight reduction. That has an immense effect on the treatment of infertility in PCOS. Loss of about even 5 to 10% of body weight will restore the reproductive function. So less dose of clomiphene and gonadotropins are required if the weight reduction is there. So the patient has to be advised proper diet, exercises. Anti-obesity drugs is controversial. So main is that the weight should be reduced. Counseling is very important because these patients, they are very high responders to treatment, and that may lead to ovarian hyperstimulation syndrome, multiple pregnancy, and they may require fetal reduction. So counseling is very important before starting any treatment. What are the modalities? There are the pharmacological and surgical modalities. So let's see how can we treat them. First is the clomiphene citrate. Although letrozole, that is the aromatase inhibitor, has taken over clomiphene citrate, but still clomiphene citrate is the preferred drug of choice. It is a selective estrogen receptor modulator. It has a selective estrogen receptor modulating action, and it binds with the hypothalamic and pituitary estrogen receptors. And because of that, estrogen concentrations, they are falsely perceived as low, which leads to increased GnRH production and increased FHNLH, and leads to multiple follicle formation. So here the clomiphene will act. The starting dose is about 50 milligram per day for 5 days, and then each cycle, if you can increase by 50 milligram according to the response. It has a long half-life of 5 to 7 days. So you can start from the second day of the menstrual cycle up to 5th day for 5 days and start the monitoring the ovarian follicles from 10th day of the cycle. Monitoring is very important in any kind of ovulation induction that I'll be talking in details later. So what are the results? 70 to 80% will show evidence of ovulation. 40% of these will conceive. 5% may have multiple pregnancy, and 20 to 25% will be clomiphene resistance. Complications are very rare with clomiphene. Few minor complications are there. OHSS can result, but it's very rare. So why there is so much discrepancy between ovulation and pregnancy? Because it has an anti-estrogenic action on the cervical mucus and endometrium. So there's suppression of the endometrium, and there are high LH levels, so that leads to less pregnancy rate. So we must know, when we talking about clomiphene, we must know what is clomiphene resistance. When the patients fail to ovulate for 3 cycles continuous, then it is called as clomiphene resistance with a maximum dose. And if the patient fails to conceive after giving 3 cycles, she is ovulating but she is not conceiving after 3 cycles, then it's called as clomiphene citrate failure. So when such thing happens, we have to rule out other reproductive dysfunctions and other causes of infertility. And this may also because of the anti-estrogenic effect of clomiphene citrate. So initially clomiphene citrate was very indiscriminately used. So RCOG and ACOG have given recommendations that this should be used for a maximum of 12 months in a patient's lifetime and for maximum 6 months continuously. Because the concerns were there is a possible linkage with later life with ovarian cancer, has led to giving these recommendations. Then what are the adjuvants which can be used with clomiphene to improve the ovulation and pregnancy rates? Corticosteroids can be given if there are high levels of DHES, dexamethasone 0.5 milligram per day, 5 milligram per day. Estrogen may help in improving the anti-estrogenic actions, but it is not recommended. Then bromocriptine is given if there is galactoria or if you see that the prolactin levels are increased. Now a word about metformin. It's a very important drug and very much talked about and hyped. It is an insulin sensitizing agent. When PCOS studies were done and comparison of two drugs were done alone or in combination with clomiphene was found to be better than it was combined with metformin. So the only indication we can find now for metformin is it is clomiphene resistant woman. You can combine metformin or before proceeding to drilling or treatment with gonadotropins, or it may be added to clomiphene in women with clomiphene resistance who are older and who have visceral obesity. So now we find indication of metformin in obese women. Also in type 2 diabetes and those who are going in for weight loss. Now in whom SCG is given? It is given in women who require IVF, but in whom LH surge cannot be detected despite good follicle formation. Ovulation usually occurs after 34 to 46 hours after SCG. So IUI can be done after 36 hours. And in which woman LH surge can be detected, IUI can be done after 24 hours after the LH surge. Now the next drugs is the aromatase inhibitors, that is the letrozole, and it has, to some extent, it has replaced clomiphene. So aromatase, it is an enzyme. Aromatase is an enzyme that converts androgens to estrogen. So these aromatase inhibitors act on these enzymes, and this creates a relative deficiency of estrogen. This results in increased FSH from pituitary and increased FSH levels. So what are the indications? It is given in clomiphene resistant women who respond to clomiphene but do not conceive. The dose is 2.5 to 5 milligram per day. Advantages of letrozole over clomiphene is that it has no receptor action, it has no effect on the endometrium and cervix, it has a short half-life, and high level of aromatase P450 in endometrium is suppressed. That causes good implantation. So the pregnancy rates, they are better, multiple pregnancy rates are less, no difference in congenital malformations, and no wear and hyperstimulation is there. Why there is no risk of multiples in letrozole? Because it has a short half-life, it does not block the estrogen receptors, and once it is stopped on the day 7, the dominant follicle grows and starts secreting the estrogen, due to which there is decrease in FSH and only the dominant follicle will grow. So it leads to monofollicular development. There were few controversies with letrozole regarding congenital malformations, but later on it was found that there was no difference in both the groups. So it is considered as safe nowadays. So what is the current evidence for letrozole? It is used as a primary agent for ovulation induction in PCOS. It is a beneficial endometrial receptivity, equal results in the patients who has undergone laparoscopic ovarian drilling, and safety profile is good, and it is in compared to gonadotropins, there is low cost. After these two drugs, the next therapy is gonadotropins. If the patient does not respond to these oral drugs, next is the hormonal preparation, that is the gonadotropins. So it is given in patients who are CC resistance or they have failure. What is the type of gonadotropins that can be used? That is the HMG, that is human menopausal gonadotropins, highly purified urinary HMG and FSH, recombinant FSH. FSH is preferred or HMG in females with PCOS because there are high levels of already in PCOS, and HMG has combination of both. So there are different protocols. So these are the different protocols for gonadotropins. I would not go much in details, but there are few protocols like fixed dose regimen, 75 to 150 international units started from day 2 to 3. This protocol is simple and it is followed with good results and outcome. So this is the low dose. Next is the low dose step up regime. Started with low dose, that is 37 to 50 international units, and then E2 and USG are done on day 7. And if E2 level is more than 200 or follicle size is more than 10 mm, same dose is continued until desired follicle is reached. Then individually adjusted regimens guided by the ultrasound, folliculometry and serum E2 levels. There are step-up protocols and step-down protocols. So what are the results with gonadotropins? Pregnancy rate, it is in CC-resistant women is 5 to 15% and the cumulative pregnancy rate is 30 to 60%. Multiples is 15%. Miscarriage rate is high, 20 to 25%. And there are certain chances of OHSS. So gonadotropins can also be combined with CC. So these are the few protocols which can be combined. Combination, and there are few advantages of this. That there is a reduction in the dose of gonadotropins and cost is also reduced. And clomiphene citrate resistant and ovulatory women, they are very sensitive to low dose of gonadotropins. The next protocols are gonadotropins and GnRH agonist protocols. These are different protocols which are used by infertility specialists. So I will just go through it. And the next protocol is gonadotropins with antagonistic protocols. The results, they are very favorable and very good. Ovulation rate is about 50 to 80% and pregnancy rate is 80% after 6 to 12 months of treatment. Results, advantages are that monofollicular development and no risk of multifetal pregnancy and OHSS with antagonistic protocols. Now we can add dopamine agonist if there is galactoria and prolactin levels, they are raised to improve the ovulation and pregnancy rate. These are the doses of bromocriptine. Now let's talk about laparoscopic ovarian drilling. It is done in women with clomiphene resistance or failure or high levels of LH. Monopolar cautery is used for destruction of the ovarian stroma, which causes destruction of the androgen producing tissue in the ovary and which results in increased FSH. 40 to 90% of women, they conceive, ovulate and half of them conceive. But the risk are radiations and decreased ovarian reserve. These should be reserved in women who are not willing to afford cost and risk of gonadotropins. Then last chance and an option for PCO patients is the in vitro fertilization. It has high success rates with supernumerary embryos which can be preserved for future, and this can modify the risk of multiples. The side effects and cons is that it's expensive and may lead to hyperstimulation. So there's a word I would like to talk about: monitoring, how these women should be monitored. Monitoring is must. Why monitoring should be done? It should be done to evaluate the dose, whether it's being used is optimal or not, to adjust the dose of your drugs, to find optimal timing of the ovulation inducing drugs, timing of IUI, and to avoid ovarian hyperstimulation and multiple pregnancy. Patient is monitored by E2 levels, that is estradiol levels, USG alone or by both, by color Doppler or by other hormones. Now when a woman is being given the ovulation induction drugs, day 2 transvaginal sonography is very important. It is done to see the antral follicle, to rule out the cyst, to see for endometrial shedding or any pelvic pathology. On this day 2 scan, we expect normal ovaries with small follicles. And follicle monitoring is started from 7th to 8th day. We usually start from the 10th day. And in gonadotropin cycles, it is start even earlier. The follicles, they grow at the rate of 2 to 3 millimeters per day. When the follicle reaches 18 to 20 mm, it is a mature follicle. It correlates well with the serum estradiol levels. But now USG monitoring has replaced the estradiol levels. Now, follicle Doppler studies, they are very important. So when we many times see that the good follicle is developing, but it is not being converted into pregnancy. So there is less blood supply and that results in lesser pregnancy rate. So mature follicles should show at least 3/4 at its size, should show vascularity. PSV should be that the peak systolic velocity of this Doppler should be 10 centimeter per second. At this time, LH surge starts, and this time is to give the HCG trigger. So rising PSP and steady or low RI suggests follicle is close to rupture. If the PSP is decreasing and RI is rising, that suggests the follicle is likely to become the unruptured luteinized follicle. And if fertilization occurs at PSP of less than 10, it suggests that an embryo is with an chromosomal abnormality. So this is the perifollicular vascularization grading. So it is a grade 3 and grade 4 is a good follicle. So HCG trigger is given when follicle size is 18 to 20 millimeters in gonadotrophins and 20 to 22 millimeters in clomiphene cycles. Ovulation is confirmed when there is disappearance of follicle or presence of free fluid and smooth hyperechogenic endometrium. IUI is done 36 after HCG. Now there are LH kits available in the markets that can be used to detect the LH surge. In some females, premature LH surge occurs in 25% of females, and it can occur at a follicle of 16 mm. So urinary LH kits are available which can detect the LH surge, and if you detect this LH surge, SAG is given at that time, and IUI can be done 24 hours after that. So what are the chances of conception in IUI cycles? 50% of women below 40 years conceive within 6 cycles of IUI. Who do not conceive within 6 cycles of IUI, half will do so in next 6 cycles. Cumulative pregnancy rate is 75%. Now word about ionositols and PCOS. There are 2 types. These are the newer drugs which have come up, and studies have been done and evidences have been collected on ionositols and PCOS. Myo and D-chiroionositols. Now what is the role of these 2 ionositols? These ionositols, they are incorporated into cell membranes as phosphatidyl myoinositol, which is a precursor of ionositol triphosphate. And this acts as a second messenger for hormones including insulin and FSH. So defects in this pathway leads to impaired insulin signaling and cause insulin resistance. So these 2 ionositols can reduce insulin resistance, improve ovarian function, and reduce androgen levels. They can be given as monotherapy or in combination with other treatment modalities. While myoinositols is necessary for metabolic management, and D-chiroionositol is important for menstrual, ovulatory, and cutaneous hyperandrogenic symptoms. So both myoinositols, they are important. Dose is 4 gram per day, 2 gram twice a day. 3 months prior to ovarian stimulation is effective in normalizing ovarian function, improving oocyte and embryo quality, and it is given in the ratio of 40:1. So what are the take-home messages? When we talk about PCOS and infertility, before starting any treatment, counseling is very important regarding weight management and the future risk if she conceives. So that is very important. First line is obviously medical therapy in the form of clomiphene and letrozole. Second line gonadotrophins. Third line is IVF. And in all the things, monitoring is very important because there are risk of ovarian hyperstimulation and multiples. And obviously, a multidisciplinary approach is necessary. We have to include a dietitian and endocrinologist. Obviously, obstetrician is there. A radiologist sometimes is also involved. So, thank you for patient hearing. Thank you very much.